Okay, 2C, blood pressure and pre-testing, pre-exercise testing instructions. So blood pressure, systolic blood pressure is the contraction phase. Diastolic blood pressure is the filling phase, and the pulse pressure is the systolic minus the diastolic. So systolic is the top number, diastolic is the bottom or lower number. There's mercury columns, there's aneroid columns, which are the dial. And also you'll see a lot of automated blood pressure cuffs. They should be made sure that they're tested for accuracy. But I mean, you're going to use whatever the facility has. A lot of times you'll see the automated devices when you go to a drugstore, and you'll see the little thing where you can put your arm into. Those things are good and recommended, especially if you're just trying to keep tabs on your blood pressure. I recommend that every family should have some sort of automated device. Automated devices are relatively cheap, $50-$60, I'd say, in many instances, and especially for older members of the family, the blood pressure can be high. So keeping track of that and measuring it on a regular basis is important. For you, if you measure it every once in a while, that's good, and if it's high, then you keep tabs on it. That's great. It's less of an issue, but as you get older, the rates of individuals with high blood pressure is very high. About 75% of people over 70, I would say, have high blood pressure. So especially as you get older, to monitor the blood pressure on a regular basis is important. The arm devices are better than the wrist devices. Oops, next. Cool. Okay, so the procedures. I will gloss through the procedures. We'll talk about the procedures in lab. I'm going to really talk about these procedures as it relates to issues you might have in the actual blood pressure values. Patients should be seated quietly for 5 minutes. Yeah, a lot of times this doesn't happen. You go to the doctor's office and you sit down. They start talking to you. They put the blood pressure cuff on, and while they're talking to you, the automated cuff is getting the values. So they're trying to save on time, but that can cause the blood pressure to be a little bit elevated. So if you're doing a blood pressure measure, the individual should sit quietly, and then you should not speak to them while the measure is being taken. So if they smoke, they should, or you consume caffeine, you should wait at least 30 minutes before the measurement. Okay, so with measuring it supine and standing, the big issue there is that if you stand up quickly and the blood pressure doesn't normalize, then the individual might have issues with regulating blood pressure. So as you're laying down, you'd expect it to be a little bit higher, and then when you stand, the blood could go more towards the feet, and then it may drop. So if your circulation isn't appropriate, then the blood pressure may drop, and that could be an issue. You want to make sure that the blood pressure cuff fits properly. If it's too big, the blood pressure may be artificially low, and if the blood pressure cuff is too tight, then it may be artificially high. The procedures we'll talk about them in lab. Yeah, we'll talk about the rest of those. We'll talk about the rest of that in lab. There are different size cuffs, so again, make sure you have the appropriate size cuff. Some people might need a large cuff. So measuring exercise blood pressure, that is a hassle and a pain. If you're in a cardiac rehab facility, then they may measure blood pressure during an exercise test and during exercise. However, if you're dealing with a general population, you probably won't measure blood pressure during exercise. Oftentimes, the issue is it's hard to differentiate the sounds of the heart rate, versus the sounds of the treadmill. So you have to be able to differentiate between what's their stepping versus what's their heart rate. Things like the elliptical machine probably make it a little bit easier. The bicycle makes it a little bit easier. So some of these quieter machines, but a treadmill is definitely loud. So that's really the main issue, and you want to make sure that the blood pressure cuff is at eye level. Potential sources of error: you can have an inaccurate sphygmomanometer. I think I pronounced that correctly. So the blood pressure monitoring device could be inaccurate. You want to make sure that it's accurate. Make sure that the cuff size is correct. Auditory acuity of the technician. So how well can you hear the blood pressure? And it depends on the patient as well. If you're dealing with an obese older individual, it may be a lot harder to hear the blood pressure, and you might have difficulty putting the bell of the stethoscope in just the right spot where it should be. So you deal with some of those issues. In a college population, when you're doing blood pressure on each other, it should not be all that difficult to hear blood pressure. For resting blood pressures, once you develop a little skill, it's really not that hard. But you will find instances where it can be challenging. Rate of inflation or deflation. Some people just inflate it and deflate it very quickly. You want to make sure that the deflation rate is about 1 to 2 millimeters of mercury per second. Make sure it's reasonable. As with the auditory acuity, the experience of the technician, they go hand in hand. Faulty equipment, that goes together with inaccurate sphygmomanometers, so I don't know why they mentioned it again. Making sure you place the bell of the stethoscope in the right spot, that's important. Not having the cuff at heart level. If there's some sort of strange abnormality, reaction time, background noise, and really the patient holding on if it's during exercise, that can elevate the blood pressure. So their arms should be free, but oftentimes if they're exercising, especially if it's an older individual, they may have balance issues. But blood pressure during exercise is challenging. If it's something that facility needs, then that's a skill you have to develop. But in most instances, we take resting blood pressures. It should be done on a regular basis, especially for middle-aged and older populations, or individuals where you know that they have high blood pressure or have a history of high blood pressure. Maybe they're taking medications and it's been regulated, but in those instances as well, make sure you take the blood pressure on a regular basis. It's relatively easy, so it's something that should be done. And if you do it with an automated cuff, that's fine. That's fine. That's one way of doing things, and really, it ends up being cheaper than to try to get a stand-up sphygmomanometer and stethoscope and things like that. So this gives the classifications of blood pressure. I think you can read that. Now, one thing that I think you should look at is that lifestyle modification is a part of therapy. Oftentimes, it's not done, but it's still a part of the therapeutic modality. So people should be doing the lifestyle modifications. That's not optional. It's what you should be doing. Now, they also tell you whether or not you should be taking medications. You have compelling indications. So see people with heart failure, cardiac disease, kidney failure, those types of things. Those individuals listed on B on the here we go. Let's see. Oh, let's go back. Let's go back. Come on, back. There we go. So B listed right here as the compelling indications. So typically, if you have any type of high blood pressure, you should be on lifestyle modification, as well as you should be taking a medication. So you don't just do the exercise and diet and hope that it gets better. You need to do both. Now, if the blood pressure goes back down to normal, and especially if it gets low, then you may take the medication away. But that's up to a physician. If the blood pressure is what's termed as stage 2 hypertension, then individuals may take a combination of two different drugs, two different blood pressure lowering drugs, to try to normalize and get the blood pressure to a normal level. Again, if you have stage 1 or regular hypertension and you have one of these indications, compelling indications, then you may also take a 2-drug combination to try to get that blood pressure into the normal range. Getting blood pressure into the normal range is very important. We want to make sure people do it. Of note as well is that normal blood pressure is below 120 over 80. So if it's 120 to 139 and 80 to 89, you're pre-hypertensive. So oftentimes people consider that to be normal, and technically that's not normal. That's pre-hypertension. So in those cases, you monitor it, you engage in lifestyle modification, and you just keep tabs on it. And if it starts creeping up and going up into stage 1 hypertension, then you probably need to be put on medication. But one thing to keep in mind is that even if you're on medication, you still need to do the diet and exercise. It's not an either or, it's a both. So classifications of blood pressure. One thing that you could do, they mentioned the JNC7 and JNC8. I'm going to do a quick Google search. Whoops, come on. Bring that over here. So, as you can see, I was looking at the ankle xanthomose, however you pronounce that. So you just put in, you can put in JNC 8, and it brings up the guidelines for hypertension. You should look for something that looks like CDC. This is a NIH. Here we go. NCBIs and NIH. So then it brings you to this document, which talks about the recommendations. What I'll also mention, they have different types of ways that they're looking at it. Let me see what this looks like. Now here we go. JNC7 was clearer in this instance. And the reason why I want to show you this, one, it's fairly easy to find, and you can see that it's it's by the government, it's by NIH, and when you look at who wrote it, it's a large group of people, and it's the professionals in the field. So it's not just somebody that made this up. Everybody should be following this. A lot of organizations here that approved this document, and then it gives you the recommendations and various things. For one, you can find this information, which is nice because you may graduate. Hopefully you graduate, and that's the plan for you to graduate. And then you're out in the field and the recommendations may change, or you don't have access to your old books. You sold them back, which you shouldn't do. You should keep them as a reference. But even if you keep your old books as a reference, the recommendations can change. So to look this information up, and it is available, you just need to know where to look. If instead of JNC7, they have various other things you can look at here. You could just look at blood pressure guidelines. And there you should look for something that's NIH related. And that should hopefully, see here the 7th report. It should bring you to something you recognize, and then you see, okay, Joint National Committee, that's what I should be looking for. I see GNC. Oh yeah, I remember that from class. and say, okay, that's the document I need to go to. So these documents are not that difficult to find. They are available to you. Move that over here, out of the way. Okay. Come on, make it big. There we go. So they have a classification scheme. They have evidence-based guidelines for management of blood pressure. And again, they want you to do the diet and exercise, as well as decrease your alcohol consumption, as well as stop smoking. You know, if you have these things that are wrong, they want you to make sure you rectify them. But keep in mind, especially as we get older, that you may be doing everything right. You may eat well, you may exercise, but due to your genetics, you still have high blood pressure. And those individuals should be taking the medication because, for one, there's nothing to fix. So you're already doing the exercise. You're already eating a low-salt diet. You're already eating plenty of fruits and vegetables and whole grains and things like that. There's nothing really to fix. The only thing that you can do in addition is to take a medication. And that is what the medication is there for. So people should take the medication in those instances. It's been very well proven that that high blood pressure will increase your risk of stroke, increase your risk of heart disease, and decreasing blood pressure will save lives. There was a seminal study many years back, and they gave some people blood pressure medication, and they didn't give blood pressure medications to the other individuals. And after a few years, they were looking at the results, and they were blinded to who was in which group. And what they found was that the results in one group were so significant that it was unethical to keep the other group from getting this treatment. So in essence, they found that, hey, if people were taking, and the group was the people taking the blood pressure lowering medication. So it became very evident that regulating and normalizing blood pressure will save lives. And that's why you see a lot of blood pressure medications, and you'll see a lot of push to make sure that people monitor their blood pressure as well as treat their blood pressure if it's high. Let's see. I'll just read this. The scheme proposed by JNC7 remains a widely accepted classification. Recommendations on specific medications used in the management of hypertension in adults see the JNC8. So basically, they didn't change the basic recommendations from the 7 to the 8. And the American Society of Hypertension and the International... okay, so those are the people that made the adjustments. The relationship between blood pressure and cardiovascular risk is continuous and consistent and independent of other risk factors. So it's a very important value. Lifestyle modification is the cornerstone of therapy. Oftentimes it's ignored. People don't do it. They just go to the medication. And again, the medication is important. People need to take the medication. But they also need to do the physical activity. They need to get their weight down to a reasonable normal weight. They recommend the DASH diet, which is rich in fruits and vegetables, low-fat dairy products, reduced saturated total fat, and reduced dietary sodium. And the dietary sodium is pretty significant. And moderate the alcohol consumption. It's not listed here, but smoking should also be. Individuals should not smoke. So for resting heart rate, so that's it for blood pressure. For resting heart rate, below 60 is bradycardia, so it's a slow heart rate. 60 to 100 is normal, and above 100 is tachycardia. Oftentimes when you see these, you have to kind of put them into context. So if a blood pressure is above 100, when is that normal? Come on. Nothing? Okay. When you exercise, it's normal. When is it normal if it's below 60? It's normal if it's below 60 is if you're an athlete, especially an aerobically trained athlete, and you have increased vagal tone, so increased your parasympathetic stimulation is greater, and then the resting heart rate could be below 60. So in those instances, it's normal. But if somebody is in some sort of ventricular rhythm or they have some sort of heart block, a third degree heart block, their heart rate might also be below 60. And in those instances, it's not normal. So you kind of have to put it into context and see what's going on with this individual to say, okay, this is a normal heart rate, it's not a normal heart rate. Also, with tachycardia, are you exercising or are you just sitting there? If you're just sitting there and your heart rate is, 120, 130, 140, that's high. That's not normal. So what is going on? What's causing that? What do you do with that? So as well as what is the heart rhythm? Locations for heart rate measurement. Oscillations, the third intercostal space. So that's if you're measuring it or listening to it with a stethoscope. You've got the brachial pulse, the carotid, or the brachial would be in your arm. The radial would be in your hand. The carotid would be in your neck. Temporal would be in your head. Most people don't do it that way. Most people will either do the carotid or the radial pulse. So count for 30 to 60 seconds. Generally, if at rest, you might still see people measuring the pulse kind of the old-fashioned way. But we have so many devices that now measure heart rate, from the activity trackers that have that heart rate option, as well as the polar heart rate monitors that you need to buy that have the chest strap, as well as the watch associated with it. Those things are really, especially if you're trying to measure it during exercise. I mean, that's kind of the go-to. Back in my day, I was in grad school in the mid to late 90s, and even then, that's when Polar just started coming out with their heart rate monitors. The only way to really measure heart rate was either through an EKG, which was obviously not practical while you were exercising, or to stop your exercise and try to take a heart rate, which was also kind of inconvenient. I'm working out, I don't necessarily want to stop, as well as when you stop the exercise, your heart rate starts to drop pretty much immediately. So there were definitely some issues with it, but now with the various types of technology, determining a heart rate is fairly easy. Heart rate can fluctuate, stress, time of day, eating. It's lower if you're in the supine or the laying down position than sitting or standing. It can be an indicator for cardiorespiratory fitness, but not always. The basic ECGs, I mean, I figured you got this in anatomy and phys, and I figured you probably got it again in exercise phys, but I'll just mention it real quick. The P wave, depolarization of the atria. PR interval is the delay at the AV node, so how much time does it take between the depolarization of the atria towards the depolarization of the ventricle, which is the QRS complex. ST segment and T wave is the ventricular repolarization. These are important in cardiac rehab if a person has had heart disease or a heart attack, to look at these values and see, okay, how is this changed? Are they looking normal? Are they abnormal? Do they look different than the way they should? Those types of issues. One thing that I think is important for you to kind of know about with these leads is there's the single lead, which is just looking at the heart in one plane, versus the 12 lead ECG. And the big benefit of the 12 lead is that you get multiple views of the heart. Yeah, I think it's here. So if there's something wrong electrically with the heart, if the beat is not going properly from the SA node to the AV node to the bundle of His to down the bundle branches and the Purkinje fibers, if that's not normal, you will see that on every lead. But if you have a part of the heart that's not receiving an adequate blood supply, and there's differences as the electricity goes through one little section of the heart, then the 12-lead ECG is better for that. So it depends on what you're looking for, what you're trying to figure out. If you're trying to figure out that ischemia, so decreased blood flow, plaque buildup or blockage or heart attack, the 12-lead is definitely the way to go. If you're just looking at what's the electrical function of the heart, then the single lead is fine for that. The next couple slides. Come on. There we go. So this just shows the different types of leads. Lead 2 is typically what you're seeing. This is what the leads look like. So you'd also have a electrode here, an electrode here, and one down here and here. So right arm, right leg, left leg. You will also see those, and this is the way it looks on an actual person. That's it.